that this particular group is non-fermenter. From your earlier knowledge, now you know that the organisms, we can classify the organisms on the basis of their nutritional demand as, or fermentation procedure, oxidation procedure, we can divide it as fermenters, lactose fermenters, non-lactose fermenter, non-fermenter, and late lactose fermenter. What is the concept behind it? We have discussed it before. Fermenters, they have two particular enzymes with them. One is permease and another enzyme is galactosidase. With the permease, you can remember the lac operon during your biochemistry class. When a particular bacteria is inoculated in a media containing lactose, the lac operon gene is activated. The permease present of the lactose fermenter group, they helps lactose to incorporate within the cell. So permease helps push the lactose inside the bacterial cell, bacterial body. And galactosidase, it is the splitting enzyme that splits lactose to simpler form glucose, from where they acquire their energy. So fermenters, lactose fermenters must have two enzymes. One is permease and other one is galactosidase. In case of late lactose fermenter, example is Shigella soni, late lactose fermenter. It produces lactose fermentation colony, lactose fermented colony like pink colony after few days, 4 to 5 days. That's why it is called late lactose fermenter. So this particular group, late lactose fermenter, permease is absent. So that particular push absent. By osmosis, they adopt through cell wall, they adopt the lactose, and then they have that particular enzyme, galactosidase, by which they split lactose to simpler form. So permease absent, galactosidase present. That is the example of Shigella soni or late lactose fermenter. Either permease or galactosidase, anyone is absent, is non-lactose fermenter. Non-lactose fermenter. And non-fermenter, both the two enzymes are absent. So permease, no permease, galactosidase absent. Now, they have to adopt a different pathway for their nutrition. Maybe oxidative pathway, then they will be called as oxidizer, or from amino acids, from lipid, they can be able to synthesize their nutrition. They are then, usually we call them as a saccharolytic group. So, the saccharolytic group is the fermenters, and asaccharolytic group, the non-fermenters. Oxidizers, they are also oxidase positive. Now, to identify fermentation procedure, we have this lactose within our media. To identify whether it is lactose fermenter or not, Escherichia coli quickly ferments lactose, but usually avoid sucrose. Usual groups of Escherichia coli, they are non-sucrose fermenting. They avoid sucrose. Usually, 65% of Escherichia coli, they avoid sucrose. Similarly, These particular group, Pseudomonas, Acinetobacter, Burkholderia and Stenotrophomonas, those are drug resistant. They are called opportunistic organism. They are always in search of opportunity. When the immune system is low, when the patients are taking corticosteroids, renal transplant, or that there are different causes of immunosuppression during the hospital entry, hospital admissions, long hospital stay, this particular group, they take the opportunity to infect that particular person. A person suffering with Escherichia coli infection, at the end of that particular person's hospital stay, when they are returning with a resistant strain of organism, multi-drug resistant strain of this particular group. So we have to identify the general characteristics first. We must know the general characteristics. What are they? They are lactose fermenter, non-fermenters, asaccharidolytic. This is the basics. How to classify this particular group? Simply, for you people, Pseudomonas, Acinetobacter, Burkholderia and Stenotrophomonas. Just remember these 4 names. This is enough. Although, on the basis of rRNA homology group, the entire Pseudomonas group is further classified into fluorescent group. If we keep the plate where Pseudomonas producing pigment, that pigment is diffusible, diffuses out in the media. In contrast to Staphylococcus aureus, where pigment is restricted to the colony only. Pigment of Pseudomonas diffuses out in the media. The entire media is colored as green or blue or whatever it may be as per the pigmentation of Pseudomonas. So that Pseudomonas group, one group is fluorescent. If you keep it in the dark, it will fluoresce. So the fluorescent group includes Pseudomonas aeruginosa, Pseudomonas fluorescent group and Pseudomonas putida. Similarly, there is a non-fluorescent group known as Pseudomonas sturgeri and Mendocina. The second group of this is important because this Burkholderia pseudomallei on Burkholderia malai and Burkholderia sericea complex. This particular group is usually present in the IV fluid. It is usually present. Sometimes it may be there within the IV fluid. So always check the IV fluid before you start. Whether there is any deposit, any material floating inside the fluid, expiry date, check everything. The Burkholderia malai, pseudomallei, they are the hospital acquired, most important strain, and they are drug resistant too. Covanomonas and Acidophorax are rarely seen. Brevudimona, the group 4, are rarely seen. Stenotrophomonas multifida is a really fatal, and almost always it is present, almost 90% cases. If the ventilator is not properly maintained, not properly sterilized, it is usually a ventilator, the cause of ventilator associated pneumonia. The casualty of the ventilator associated pneumonia is mostly due to this particular group, Stenotrophomonas multifida and Acinetobacter baumannii. Although Acinetobacter is not there within this group, this is the classification of Pseudomonas. So within that classification, we are getting here Pseudomonas, Burkholderia and Stenotrophomonas. What are the virulence factors? Only to remember these particular points during reading of Pseudomonas or non-fermenters. LPS, the role is antiphagocytic, lipopolysaccharide of gram-negative bacilli. It is known to you. Villi, the adhesion and biofilm formation. The adhesion molecules and biofilm is the extra polysaccharide on the devices, maybe it catheter, maybe cardiac valve, artificial prosthesis, anything. Within 48 hours, it is colonized by the normal flora, mostly initially by Staphylococcus epidermidis and subsequently by Pseudomonas and any member of the Pseudomonas group. Flagella, motility as well as adhesion, and the exotoxin A, it is cytotoxin, destroying the cells, that's why it is called cytotoxin, and it is similar like diphtheria toxin, the exotoxin of diphtheria. What is the function of exotoxin of diphtheria? It blocks the polypeptide synthesis. It blocks the polypeptide synthesis. The proteases, a proteolytic and cytotoxic, and capsule overproduction of alginate results mucoid colonies in cystic fibrosis patient. Cystic fibrosis is a condition. It is a lung disease, and where if you see the chest, that multiple cystic spaces are formed within the lung, and increased air traffic. So this cystic disease, within this cystic disease, a thick tenacious sputum is formed, and that particular sputum is due to this alginate, due to the alginate of the Pseudomonas group, because it adhered with its capsule with this particular cyst within the lung cavity. The general characteristics, it failed to acidify and oxidative fermentative Hughes Lifson media. We have one media, I'll show you the picture, Hughes Lifson media, which you usually use to recognize oxidative procedure and fermentation procedure. This oxidative and fermentative procedure is seen with overlay with mineral oil to make the particular media anaerobic and one aerobic. The Pseudomonas is oxidase positive. That means aerobically it utilizes glucose, non-fermenter, but aerobically it can utilize glucose. So the similar property, we check it with the OF media, a special media. And the one important thing, the TSI media, the triple sugar iron media, where we see K by K reactions, alkaline by alkaline reactions. No acid is formed, no fermentation. The oxidase positive is the unique characteristics of this group is oxidase positive. Ubiquitous in the environment, always present in the environment, everywhere. And it colonizes of the hospital, it colonizes within the instruments, within this tube, within this humidifier. We have to check this humidifier every time the patient is discharged. Then we must check this humidifier and entire the tube. We have to replace it if possible. The endotracheal tube, we have to replace it with each and every time. The nebulizers, the catheters, rarely they are the part of the normal host microbiota, can easily colonize hospitalized patients, immunocompromised, and it is resistant to multiple drugs, as I have mentioned. The clinical infections they produce, there is septicemia, meningitis, osteomyelitis, and wound infection. These are the 4 infections common for all this particular group. So if there is any short note on Acinetobacter or short note on Burkholderia, Stenotrophomonas, these properties are common because they can produce the same type of infections in case of this particular group. The clinical conditions, the patient usually immunosuppression, immunocompromised, there must be a trauma, usually a trauma. In trauma patient is burn patient or surgery patient, bullet injury, where this particular group of infections are seen. Foreign body implant and infusion fluid, as I mentioned in case of Burkholderia. The biochemical characters. This is the picture of TSI, K by K, alkaline by alkaline, and in case of acid by acid, in case of Enterobacteriaceae. Enterobacteriaceae, they ferment glucose, lactose, etc., and that's why acids are produced. So this is the picture of acid by acid or TSI media, triple sugar iron media, and this is K by K. This one is K by K, K by K, and this is the Hughes Leveson media with overlay of liquid paraffin to prepare to make this environment anaerobic and to see the oxidative fermentation is there or not. So no acid reactions in the anaerobic portions of TSI, K by K, no gas. Antibiotic sensitivity test to third generation and fourth generation of cephalosporin, ceftazidime and cefepime. They are the third examples of third and fourth generation cephalosporin. They are resistant to this. Aminoglycosides like gentamicin, amikacin, etc. Penicillin, quinolones, ciprofloxacin, norfloxacins. And they are resistant, usually sensitive to this third gen and fourth gen, and aminoglycoside, penicillin, quinolones are usually sensitive, but we have to check the antibiotic sensitivity test before you start any therapy. The glucose OF test is negative. Based on the site of isolation. This is a very important point. The site of infection, the site of isolation. From a normally sterile site, what the sterile sites in our body? Our blood is totally sterile. Pleural fluid, ascitic fluid, these are usually sterile. But in case of sputum, multiple organisms are seen in sputum. Urine, usually one, maximum two organisms are accepted. Stool, polymicrobial. So these are the polymicrobial site, and this particular sterile site, that means organisms are not expected over there, and this is particularly our blood. Requires definitive identification. Susceptibility testing is absolutely required there, where you get this particular non-fermenters group, that is oxidase positive group and non-fermenters. From a non-sterile site in which 2 or 3 other bacterial species are also present, the genus identification might be appropriate by biochemical test like oxidase, growth on MAC agar to check it whether it is lactose fermenter or not. The utilization of glucose, the two terminology we use, one is the fermentation procedure and other one is the utilization procedure. Lactose fermentation and lactose utilization. Glucose fermentation and glucose utilization. Please go through your textbook to particular these two terminology, what is fermentation and utilization. So they are utilized, and indole and motility test are very important because the motility, with the help of this motility test, we can differentiate Acinetobacter and Stenotrophomonas. The typical pigmentation is a unique property of this group. The pigmented strains are Pseudomonas luteola, Pseudomonas sturgeri, and Sphygmomona possimobilis. Rarely, these particular groups are identified. The purple color, what we see in McConkie media, in case of Acinetobacter, it is very difficult to identify this purple color. Blue-green color in Pseudomonas aeruginosa, violet color in Chromobacterium violacea. So the bacterial world is very much colorful. The wrinkle colonies, these are the example of wrinkle colonies. You see these wrinkle colonies. The wrinkle colony in Pseudomonas sturgeri, in Burkholderia, Pseudomoli, this particular wrinkle type is seen. The order usually switch in case of originosa, The Acinetobacter strains, they are non-motile, and oxidase negative Acinetobacter and Stenotrophomonas. So, Acinetobacter and Stenotrophomonas are non-fermenter but oxidase negative. Acinetobacter and Burkhold and Stenotrophomonas, Acinetobacter and Stenotrophomonas are non-fermenter but oxidase negative. Here lies the difference with Pseudomonas. How you will differentiate this particular species? Simply by testing the oxidase test as well as the motility test. The largest percentage of all non-fermenters isolated from clinical species are characterized there by GNB, gram-negative coccobacilli, gram-negative coccobacilli, strictly aerobic, motile with polar or polar tuft of flagella, polar and polar tuft of flagella, oxidase positive, catalase positive, and non-fermenter colorless colony on MAC agar, non-fermenter colorless colony on MAC agar. These are characteristic features of Pseudomonas. Mostly identified in hospital environment, in humidifier, in tap water, Sablon, Dettol, and all sorts of things kept in the OT. The selective media of Pseudomonas is cetrimide agar media. Cetrimide agar media. That means within the antiseptic, within this disinfectant, they can grow. Pseudomonas, always check Pseudomonas. A culture is advised from the OT material to check whether there is these particular groups are there or not before you start your operation. In case of sensitive operation, 6% nosocomial respiratory tract infection and 6% of all bacteremia, 75% of all nosocomial bacteremia. Third most common cause after E. coli and Klebsiella infections, and common among cystic fibrosis patients. The cystic fibrosis patient, and less serious as otitis externa, jacuzzi, and hot tub syndrome for the sportsman. And this is written in Harrison's textbooks of 17th edition to alert us. The identifying characteristics which are clearly visible from the media, the pyovardin, the yellow-green pigmentation of Pseudomonas. This is water soluble and fluoresces under UV light. The pyocyanin is a blue pigment by most strain combines with pyovardin. It produces green color of Pseudomonas aeruginosa, especially seen on Muller, Hinton, agar. This is the question, oral question, where you can see this pigmentation in maximum, especially maximum pigmentation is seen in Muller, Hinton, agar. This is a white base media, and diffuse pigmentation is very nicely seen over there in Muller, Hinton or nutrient agar. The pyorubin is red pigment, occasionally produced by Pseudomonas aeruginosa, pyomelanin, and the growth temperature is another important clue, is 42 degrees centigrade, by which you can differentiate Pseudomonas group to other group, because Pseudomonas group to other group, because Pseudomonas can withstand this 42 degrees centigrade and can grow at this particular temperature. So this one another important point to identify Pseudomonas groups. So now we are getting 3 points. One is the ferment, non-fermenters. Number 2 is oxidase positive. Number 3 is motility. And number 4 is the growth temperature of 42 degrees centigrade. Just to remember 4 points by which we will be able to differentiate all these group members of Pseudomonas. The treatment. This treatment sheet is as per our record of SMCH. This is the data what we have collected from our hospital just at this moment. The list of resistant drugs, our strains, these are resistant to penicillin, ampicillin, first and second generation cephalosporin, cotrimoxazole, chloramphenicol, tetracycline. No effect with this drug now. Our strain, what we are getting, They are maximum sensitive to aminoglycosides, that is gentamicin and amikacin. Piperacillin tazobactam is a drug of choice. In 90% cases, we are successful with treating this patient with piperacillin and tazobactam. So it is the drug of choice here at this region is a drug of choice of piperacillin tazobactam. From a pharmacological audit, we have received this picture that the clinicians have now started practicing this piperacillin tazobactam in maximum to get through these particular strains. And this is from our hospital data. Third and fourth generation cephalosporin, ceftazidime and cefepime, and carbapenems never prescribed ertapenem, carbapenem, imipenem and meropenem. They are sensitive, and fluoroquinolone, ciprofloxacin group is to some extent in 65 cases they are sensitive fluoroquinolones, and imipenem, carbapenem sensitivity is 75%. The maximum sensitivity we have seen in case of piperacillin tazobactam, it is sensitive to 90% level. This is from our data here. The key characters of P. fluorescens, Pseudomonas fluorescens and Putida are very low virulence organism and rarely cause disease, isolated in respiratory tract, blood product and hospital equipments, linked to transfusion associated septicemia and produce pyovardin, cannot grow at 42 degrees centigrade. This is an important point. And P. putida, by gelatin hydrolysis test, we can segregate this P. putida from the others. Stenotropomona, gram-negative bacilli, always present in the environment, very common in the hospital environment, regarded as colonizer of respiratory tract in hospital, and patients among the immunocompromised patients, mostly in ICU. ICU pathogen, everywhere in ICU. Be careful within the ICU because these particular Stenotropomona strains are there always. Identification by oxidase, they are oxidase negative and non-fermenter, gram-negative bacilli, bluish colonial MAC agar, the bluish hue, and catalase positive, the drug of choice for this particular group of Stenotropomona. The Stenotropomona, they are resistant to all drug, multi-drug resistant, rather pan-drug resistant, only sensitive to co-trimoxazole. So this is a very good test for Stenotropomona identification because this particular strain is only sensitive to co-trimoxazole, no other drug. Burkholderia cephacea, the 18 distinctive genovarts are there, genovarts are there, and associated with pneumonia in immunocompromised patients of cystic fibrosis and or chronic granulomatous disease, cause endocarditis, UTI, osteomyelitis, isolated in IV fluid, as I have mentioned. For IV fluid, be careful, check it, and nebulizers, etc. The selective media with antimicrobials to reduce growth of Pseudomonas. Usual media, McConkey, you can add any special antibiotics to check the growth of Pseudomonas and to promote the growth of Burkholderia. The Burkholderia cephacea, it has the selective media and we prefer the selective media. The disease produced by Burkholderia, malai and pseudomalai, the zoonosis affect mostly horses. This is the situation. Burkholderia is a bioterrorism agent and it is a gram-negative coccobacilli and it is non-motile in compared to Pseudomonas. Pseudomonas is motile, Burkholderia is non-motile. The disease is characterized by the development of ulcerating growths that are most commonly found in the upper respiratory tract, lungs and skin. Melioidosis, an aggressive granulomatous pulmonary disease, it is metastatic. The non-fermenters, the wrinkle colony, I have shown it. It utilizes lactose and selective media is S-down media. The deep pink color, earthy color order is there and diagnosis is the multi-top. It is a very good instrument by which you can diagnose this particular variety. The various forms of melioidosis have been reported in the horses. Clinical signs may include weakness, edema, and lymphangitis of the limb, mild colic, diarrhea, coughing of nasal discharge, skin infections may resemble Fungal eczema initially progressing to become papular. The papular lesions, these are the papular lesions here. Chronic granulomatous lesions. The schematic diagram, diagnosis of the non-fermenters, you see these all are oxidase, maybe oxidase positive, non-lactose fermenter, non-fermenter. These are the group of non-fermenter. But oxidase test is done. If the oxidase test is positive, this oxidase test is positive, go for motility test. If motility test is positive, then this is Pseudomonas aeruginosa or alkaligenes. Now, if the motility tests are negative, it may be Acinetobacter, and with the help of utilization of 10% lactose, we can identify Acinetobacter baumannii and A. lymphi. But for you, oxidase negative, go for motility. If non-motile, then it is Acinetobacter. If motile, then probably oxidase negative, then this is oxidase negative, motility positive, Stenotrophomonas or Bode-Felderia. This is enough for you. Now the questions. A 32-year-old man with 30% burn injury developed infection after 5 days of hospitalization. Exudate was sent for culture, the biochemical examination and AST test. Now I must give the stress particularly on exudate or discharging from the lesion. The discharge, if it is thick pus, thick whitish pus, probability is Staphylococcus. If the pus is thin, liquid pus, then the probability is Streptococcus. Then if the pus is blue in color, the probability is Pseudomonas. So blue pus is classical for Pseudomonas. So what is the causative organism? Causative organism is Pseudomonas aeruginosa. In maximum cases, we isolate Pseudomonas aeruginosa. Discuss the laboratory diagnosis. How do you proceed for the laboratory diagnosis? What is the material? Pus, isn't it? Pus. Blood. Blood. Is it required? Blood চাই না চাই না? পাস তো দরকার। কিভাবে পাসটা কালেক্ট করবে? How do you collect pus? We usually prefer discharging pus in a sterile container. We try to avoid swab. Swab is not a good specimen because it dries out, and the maximum chance we want maximum amount of pus to identify a lot of organisms, lot of experimental tests. We require a good amount of pus. So frank pus is our target. In a sterile container, frank pus is our target. So sample is pus. Then we will proceed for gram staining. First step is to observe the color of the pus, then the gram staining to identify the organism, whether it is gram negative bacilli, whether it is gram positive organism or not. Next, culture. The selective media. Before we take the selective media, we have to go for ordinary media. Those media which are available in our lab, like McConkey agar to see the lactose fermentation, enterobacteriaceae group as well as non-fermenter group, isn't it? So McConkey media is preferred, and then blood agar media is also required. Why? To see gram-positive organism, to observe gram-positive organisms, isn't it? To see the hemolysis of Streptococcus. So blood agar and McConkey agar. Then next, after 18 hours, we have to observe the colony character, the nature of the colony, lactose fermenter or non-lactose fermenter, and hemolysis is there or not. any pigmentation is there or not, the type of the colony. Then we will go for motility test. Is it motile? By hanging drop preparation. Hanging drop preparation is preferred. And we will observe, we will check the motility. Pseudomonas motile, Staphylococcus non-motile, Acinetobacter burkholderia, oxidase test next. If non-fermenter, then we will go for oxidase test. Whether oxidase test is positive or not. Isn't it? Oxidase positive, motile, confirmation by testing in a selective medium, that is Pseudomonas. Oxidase positive and motile, Pseudomonas, will go for checking by selecting the selective media, like cetrimide agar media, isn't it? And then we will go for the antibiotic sensitivity test in Muller Hinton agar. And if it is Enterobacteriaceae, then straight away we will proceed for antibiotic sensitivity test. Is it clear? This is the approach by which you write any bacteria, you can write from this particular protocol. If you maintain this particular protocol, then you will be able to write any laboratory diagnosis at any time. How will you treat this case? The regional data is important. We have placed the regional data from where you have to select the maximum sensitivity drug by observing the MIC, or the zone of inhibition, maximum zone of inhibition, and as well as considering the patient conditions. You have to select the particular drug. And if that drug is intravenous or intramuscular injections with the remission of the clinical symptom, you have to switch over to an oral drug during the time of discharge. And you have to give the adequate directions for the patient for the next few coming days, because the patient definitely has a history of hospital stay. So you have to observe for hospital acquired infections are there or not. Even after a few days, you have to check the patient and you have to inform the patient as well. Question 2. Why does ICUs permit the use of flowers bouquet inside the room? Patient দেখতে আমরা flowers নিয়ে যাই, কেন আমরা নিষেধ করি যে ফুল নিয়ে যাবেন না পেশেন্ট দেখতে? অত ভালোবাসা ভালো নয়, আমরা বলি না পেশেন্টকে flowers নিয়ে যাবেন না দেখতে, because this particular group, non-fermenters, they are present everywhere. They are ubiquitous, present in soil, present even in flower, everywhere. So avoid, keep the environment clean. What does the term glucose non-fermenting gram-negative rod convey? Glucose non-fermenting gram-negative rod. By OF test, we will be able to identify the glucose non-fermenting gram-negative rod, isn't it? Lactose fermentation as well as by oxidase, by OF test. Oxidation fermentation is another test that is known as Hughes-Levinson test. This is usually done to see this, to check this. Mention the principle and procedure of oxidase test. This is important for you and this is a question. The writing style will be like that. How we have to write this answer? This is the principle of this. To determine the presence of component cytochrome oxidase enzyme which catalyzes the oxidation of the reduced cytochrome and reductions of the dye to purple color. This is the principle of this oxidase test. We will ask this in the oral table as well as in the practical test. And this is the typical answer what you have to produce at that time. The procedure of the test. The filter strip coated with Kovacs reagent TMPDAH. The name of the reagent is tetramethyl. paraphenylene, tetramethyl, paraphenylene, diamine, hydrochloride. This is asked in the oral table. The reagents, oxidase reagent is tetramethyl, paraphenylene, diamine, hydrochloride. So procedure is that the filter strip coated with these Kovac reagents and where 1 to 2 colonies with the edge of a cover slip. Why cover slip is used? If we use the inoculating loop, it may produce a false positive result. That's why the metals are avoided. We use cover slip, the edge of the cover slip by which we pick up the colony 1 or 2 and then stick on the particular filter paper to check the color change within how many seconds? Within 15 seconds there will be a color change. So that color change is important, that is purple color change, and observation time is 10 to 15 seconds, purple color appears. Interpretation, the test is positive, and we will also run a negative control to differentiate the test strain with Enterobacteriaceae. Enterobacteriaceae are oxidase negative. So we have to check the control with a negative Enterobacteriaceae, negative Enterobacteriaceae are negative. So with this E. coli, we can check this. Give examples of oxidase positive organisms. What are the examples of other oxidase positive organisms? Number 1 is Vibrio cholerae. Vibrio cholerae is also oxidase positive but fermenters. Oxidase positive but fermenters. They can ferment glucose. Vibrio cholerae. Then Pseudomonas is non-fermenter oxidase positive. Neisseria gonorrhoeae is oxidase positive. Please remember at least name of these 3 organisms. One is Vibrio cholerae, Pseudomonas aeruginosa, and Neisseria gonorrhoeae. They are oxidase positive. Name the DOC, the drug of choice in case of Pseudomonas infection. It is piperacillin tazobactam in case of Pseudomonas infections. And in case of Stenotrophomonas multifolium, what will be the drug of choice? Cotrimoxazole is the drug of choice. Never forget before you prescribe. In case of Pseudomonas, if it is seen in a laboratory report, it is better to we prefer the piperacillin tazobactam combination to avoid the multi-drug resistance. And in case of Stenotrophomonas, always prescribe cotrimoxazole, and cotrimoxazole is the drug of choice.
The different level of lymphocytic differentiation of lymphocytes, B lymphocyte, T lymphocyte, and NK cells. So already I told that is the place or the position, that location from where the leukemia starts, from where the lymphoma starts, and from where the plasma cell leukemia or plasmacytoma, malignant plasmacytoma that starts. So already I told that anatomical location or that region of the lymphoid tissue from which the different types of tumor or malignancy that arises there. So already told that is the from bone marrow, that is the Picasso B cells, from where that the leukemia, that is the ALL, acute lymphoblastic leukemia that arises from that air, that is the lymphoblastic leukemia. From there, that mature lymphocyte will come to the germinal center of the lymph node. According to the antigenic stimulation in the germinal center, they transform to the centroblast, centrocyte. From there, due to they have to produce that antibody to combat with that antigen, and they are give rise to a plasma cell and that memory cell for their immune protection. So the tumor that arises from these germinal centers are pre-germinal center, they produce the mantle cell lymphoma, and the germinal center they produce the Burkitt lymphoma, follicular lymphoma, DSBCL or diffuse large B-cell lymphoma. And post-germinal center they produce the marginal zone lymphoma and the CLL that are mutated, and that plasma cell leukemia from there in the another side. So these are the anatomical location from the origin of that lymphoma, leukemia, and the malignant plasma cell scene. So lymphoma. Lymphoma, it is a heterogeneous group of lymphoproliferative malignancy result from clonal proliferations of the B lymphocyte, T lymphocytes, and NK cell. That is the important, there is a clonal proliferation. When it is the monoclonal, that is the malignancy. When it is the reactive in nature, that lymphoid proliferation are in polyclonal in nature. And mostly the cells 85% to 90% are derived from the B cells, rest 15 to 10% are from the T lymphocytes and other cells. And these are the entities are of various clinical presentation and their therapeutic outcome. Now, what is that lymphoid neoplasm? That is the neoplastic proliferations of these white blood cells. We know that is the when it is a proliferation in malignant proliferations, this gives rise to a leukemia or lymphoma. When as the lymphoid tissue present throughout the body, in the bone marrow, in the lymphoid tissue, and in the peripheral tissue also. So that leukemia and the lymphoma, it is differentiation is very difficult. Sometimes the leukemia, as it is originated from the peripheral blood and bone marrow, sometimes without proliferation in that area, they presented in the tissue also. On the contrary, the lymphoma, as it is present in that lymph node and the tissue, without involving that area, they are presented in the peripheral blood or bone marrow. So this differentiate between this leukemia and lymphoma is a blood. So that different types of classification, various scientists they are tried for their early diagnosis, for their early treatment, planning of treatment, and the therapeutic purpose. For that things apart, the distinction is this thing is two is very important. Lymphoma occasionally presented as leukemia, or leukemia may presented with only involving the bone marrow. So this distinction is very important. For this reason, various types of classification are tried from the very beginning. It has various types, very ancient times. But now, as for example, the FAB classification, working classification, real classification, WHO classification, they tried. Previously, we don't have so much of molecular analysis for the identification of that cell of origin, that is the clonal proliferation, their translocation, mutation was not present at that time. Nowadays, WHO, due to the invent of this molecular analysis, they tried for the classification to identify what type of cell they are proliferating, that is the clonal proliferation. Why that is important? Because of this early diagnosis, assessment of the prognosis, and the possible therapeutic result. So this is for WHO they had tried due to thus invent of molecular analysis. So already I told that area that from where the lymphoma arises from the different stages of differentiation in that lymphoid germinal follicles. Bone marrow, I told these are the immature stem cells, from there they are developing that ALL that arises in the immature cells from the bone marrow, and the lymphoma in that lymph node, that is the germinal center, they produce that mature lymphocytes. Due to developmental defect, they produce the follicular lymphoma, Hodgkin lymphoma, diffuse large B-cell lymphoma within the lymphoid tissue. So these are the two things that is anatomically we can identify. Now, what is the etiology? In general, different types of etiological agents are responsible for this development of lymphoma. What are those? That is the occupational exposure. Some people they are working in that exposed to these herbicide, pesticides. Some infectious disease, as for example, bacteria, virus. They sometimes you can identify that viral origin or bacterial origin in that particular lymphoma. They are responsible. As for example, H. pylori, you know, the Helicobacter pylori or H. pylori, they are responsible for the in the stomach, that is the maltoma, that is the mucosa associated lymphoid neoplasm. So this is maltoma. Another thing that infections are HTLV virus, hepatitis C, hepatitis HPV-8, EBV virus, CMV viruses also are responsible for the origin of lymphoma. Other patients, they have immunodeficiency on those patients, they have the HIV infection, or the patient have the transplantation either in the tissue transplant or bone marrow transplant. They are immunodeficiency. Due to this, they are responsible for this type of mucosal analysis, that is the molecular transcription or molecular mutation, translocation. They are for this thing responsible. Some drugs, that is the immunosuppressive drugs, sometimes they use HIV infection but transplantation of that person. The drugs are used, they also give rise to the abnormality of the immune system, and this is responsible for this lymphoma. Some autoimmune disorder, that inflammatory bowel disorder, Sjogren's syndrome, rheumatoid arthritis, they are also autoimmune, give rise to the immune dysfunction and produce, these are responsible for those. Another thing, some patients have geographical distribution. As for example, Burkitt lymphoma, usually a patient are the African location. So some responsible in the geographical area, they are also present. So what are those basic principles in general for this lymphoma? Only you know that what are those, the history only. No need to remember the exam, they will not come as theory exam. So you know what is the entity is responsible for this thing. See this thing, this is the, when that neoplastic lesions or lymphoma, when it is suspected, how it is suspected? From that enlarged lymph node, clinical history and other things. When they are suspected, so the clinician, they what they do? They are do the needs for histopathological examination of the lymph node and the tissue are responsible for those areas. Why this is noted? Why need importance? Because the histopathological examination, that is the important for the lymph node architecture, the cell of origin, that a morphology of cells. Then that immunohistochemistry, that as it is a clonal proliferation, so immunohistochemistry for particular CD marker, we have to identify for this clonality. So monoclonal proliferation of that particular CD marker, or the translocation, that is a cytogenetic analysis, that is the what are those chromosomal abnormality, translocation, mutation, that also identify the what type of monoclonal proliferation of that CD marker, the B cell, T cell or other cells, they are producing that particular tumor. Another thing, for this categorization is important, and the monoclonal is the expression of malignancy. When it is a polyclonal origin, it is a reactive in nature. So that enlarged lymph node doesn't mean that it is a lymphoma. So when it is expression is a polyclonal, it is a reactive in nature. But when it is a monoclonal proliferation, that is a suspicion of malignancy. That is the most important thing. Next one, lymphoma. I told the lymphatic tissue are a B cell, T cell and NK cell. It may occur, mostly it is a B cell origin, and 85 to 95%, 90% is the B cell, 10 to 15 is the T cell and other NK cell is there. But this lymphoma, for our purpose, is a two broad category. One is the non-Hodgkin lymphoma, that is the NHL, and another thing is the Hodgkin lymphoma, that HL. For your exam purpose, you have to know the what is NHL, not to remember for exam also, but Hodgkin lymphoma is very important for your exam. Theory exam, oral purpose, that Hodgkin lymphoma is important. So these two broad categories is the NHL, that is non-Hodgkin lymphoma, and for important for exam is the Hodgkin lymphoma. So Hodgkin lymphoma, this is superficial groups of importance is that thing. The superficial groups of lymph node above the diaphragm or below the diaphragm, but it is in continuous in nature. That is a radicular, that is the radial fascial manner, that is the important, that is the continuous connection with that lymph node. But NHL is discontinued fashion. So haphazardly they can involved in any area. Maybe nodal, maybe extranodal. But the Hodgkin lymphoma prognosis is very good than NHL, and it is the outcome is very good prognostic in the Hodgkin lymphoma. So superficial lymph node spread orderly continuous lymph node and stepwise fashion, and it's a predictable manner they are proliferate. But non-Hodgkin lymphoma, it is disseminated widely and discontinuous manner, and it is unpredictable in that whole course. And that staging is very useful because the clinician, they will treat the patient prognostically, and their prognosis depend upon the stage of the patient. Early stage, that is a stage 1 to patient prognosis is good, and it is, if it is a late stage, that is the 3rd, 4th, prognosis is poor. So these are the some points to remember for lymphoid neoplasm. How you diagnose this thing? When the patient is presented with suspected case of lymphoma, we will do, that is a FNAC, you can do core biopsy, you can do true-cut biopsy, or you can do the total excisional biopsy of the lymph node for morphological examination. Then the immunohistochemistry for particular CD marker and molecular analysis. Other tests are peripheral blood and bone marrow examination, bone marrow biopsy, cytogenetics abnormality that I told, that is the chromosomal translocation mutation, immunological abnormality, and organ-specific test. When they involve other than lymph node, any organ that can involve in that NHL, that organ-specific examination, we have to do this thing. Then other things, all the patient they have to know the staging of the patient for the treatment purpose, and another ancillary test according to the organ involved. What will we examine? What will we see from the lymph node? We'll see, that is the excisional biopsy show the architecture, that is the normally the lymph node have the different types of follicles, may have reactive follicles or the thing. So the follicular architecture is maintained, or if it is maintained, what is the CD marker or the proliferation is polyclonal or monoclonal. If it is loss of nodal architecture, it may be diffuse. But diffuse in nature is the polyclonal in nature or monoclonal in nature. So this thing we have to identify by cytogenetics analysis, then CD marker, that is the ISC for the CD marker analysis, and chromosomal things. We have flow cytometry we will do for the B cell marker. Already we know from the previous class that CD marker for B cell and T cell you know. From there we have identified the tumor is arising from a B cell origin or T cell origin. For this we have to, for flow cytometry we have to know CD 1920 for B cell, few other also there, it's a very big list, only the 1920 for B cell, CD3, 4, 8 for T cell. These are the things we will identify. This is which group will come, it is B cell origin or T cell origin. Again, the chromosomal changes that occurs, as for example, in follicular lymphoma, that is the BCL2 oncogene, that is a 14-18 translocation. For Burkitt lymphoma, that is the 8-14, 2-8 and 8-2-2 translocation. Then DLBCL is a BCL2, BCL6 translocation. These are the things for particular type of lymphoma, they are expressed, and for this we will diagnose the case and outcome and treatment we can identify. So this patient, they are presented as a lymph node. These are the different types of elderly patient, these are the children. So all the age can lymphoma can affect it. It may be a NHL or HL. So NHL usually, all types of patient usually affected, but Hodgkin lymphoma usually younger age group bimodal, elderly occur or it may be children may occur. So these are the some features that can affect. Now, WHO 22, they have classified this big neoplasm in broad headings. But we have to note for you, no need to remember all those things. You know only a B cell neoplasm, T cell neoplasm. And these are the different types of classification, that is the tumor-like lesion, precursor B-cell neoplasm, mature B-cell neoplasm, and plasma cell. So, this is a B-cell lymphatic neoplasm. No need to remember, only you know it's a very big list that WHO they have produced, they have prepared in 2022. This is a information. Next, the T cell, that also another big list that WHO they prepare. Only you know the big list, no need to remember for exam. Only know that is a B cell neoplasm and T cell neoplasm under non-Hodgkin lymphoma. So, but we all know the only the two good broad agreed, that is one is a non-Hodgkin lymphoma, the NHL, another is the Hodgkin lymphoma. So, distinction, those two things will come one by one. And plasma cell neoplasm already you have finished. So, I am not going to that area. Now, non-Hodgkin lymphoma, these are the common what we told up to that also are present in here also. So, currently WHO, they have broadly classified into two things, that is the immature B cell tumor, mature B cell tumor. Immature T cell tumor or lymphoma and mature T cell lymphoma. Another thing is the peripheral T cell, NK cell neoplasm and the Hodgkin lymphoma. These are 5 groups. Precursor B cell, mature B cell, precursor T cell, NK cell and mature T cell, and another is the Hodgkin lymphoma. These things are WHO, they have categorized them to remember easily for you also. Now, what is the etiology of the non-Hodgkin lymphoma? Age. Age is any age, older age group is very important for non-Hodgkin lymphoma. As is older age group, they have some genetical susceptibility present in some minor, they can produce this thing. Some patients have family history because of if the patient in the family, they have different types of lymphoma or leukemia or any other genetic abnormality or other tumor, they are vulnerable to produce due to the treatment, drug induced or maybe the tumor induced, they are responsible for this thing. What are the family infection? Viral infections may be HTLV virus or human herpes virus, HHV8, hepatitis C virus, hepatitis, HIV infection, bacteria, I told that is an H. pylori bacteria they produce in the stomach, that is the Lymphoma, that is a gastric lymphoma induced by the H. pylori infection. Those patients have lower immunity, some disease they are due to the treatment they have immunity is very low. What are those things? Now, give rise to a viral infection but post-transfer lymphoproliferative disorder, they have immune deficiency or depressed immune mechanism, they are responsible for this. Some autoimmune disorder that I told, that also those patients have history of radiation or treatment of the immunosuppression they are used. These are the etiological factors to produce this non-Hodgkin lymphoma. So, now lymphoid neoplasm, what is the clinical feature? Clinical feature depends upon the lymph node involved. So, according to the location of that lymph node, clinical features are also present. So, patient, they are enlarged lymph node more than 2 cm in diameter, maybe single, maybe multiple, maybe matted. And those lymph nodes are painless and firm in nature. They don't have any pain, non-tender and the firm in nature. Sometimes they are produced maybe in the above the diaphragm or maybe in the below diaphragm. So, enlarged lymph nodes are more than 2 cm in diameter, painless, 1 or 2 groups of above or below the diaphragm, firm, rubbery and painless. Sometimes they produce that alcohol-induced pain. Due to from the history they can tell that is due to the alcohol intake, they are produced pain in that lymph node. Some what are those? They are presented with the fever, high fever. Why high fever? Because of this, that tumor cells, they release the pro-inflammatory cytokines. Due to these pro-inflammatory cytokines, give rise to a high fever. So, cytokines, chemokines release the neoplastic cell, they produce high fever. And another thing is the B symptoms. B symptoms, what are those things? Patient are presented with the unexplained weight loss, high fever and drenching sweating. This is called the B symptoms. So, B symptoms are high fever, loss of weight and drenching of the sweating is the B symptoms. See this thing? Patient with the lymphoma, they are coughing. If it is related to that lung, breathlessness, itching, that is sometimes they produce the itching, sweating, night sweat, they have loss of weight. If it is alcohol induced, give rise to a pain, vomiting and lump in that any area according to that anatomical location they produce. And these are the B symptoms are loss of weight, high fever and the drenching of night sweat. These are the B symptoms. Patient then and then the clinician will suspect that it is a case of lymphoma. This is the lymph node. So many things. These are the matted cut section. This is a rubbery form, grey, white and fish-place appearance. So the lymph node are round, oval, more than 2 cm diameter, maybe single, maybe multiple. It is and form, painless and on cut section it is feeling it is a rubbery, cut section is the fish-place appearance. This is the area. Another thing you have to know, we have lymph node, location of the lymphatic tissue in the lymph node and also in the extranodal site. So the NHL, they are present both in the lymph node and extranodal lymph node. That is very important. Hodgkin lymphoma, usually they are located in that lymphoid location, but non-Hodgkin lymphoma not restricted to the lymph node, that other than the extranodal lymph node is called extranodal lymphoma. And this is another group, but you have to know that other than lymph node, this lymphatic tissue also present an extranodal site that is also produce this lymphoma. That is non-Hodgkin lymphoma also produce. So these are the some enlarged lymph node. This what are the extranodal area. See, these are the things other than lymph node, GI tract, Welder's ring, breast, tonsil, salivary gland, thyroid, bone, orbit, CNS, skin, nasal sinus. These are the extranodal site of lymphoma. So it is not restricted to the lymph node. Our extranodal site also we have to remember that also that lymphoma can produce also in that area. Some lymphoid marker already you know, that is the T cell marker, B cell marker, stem cell marker. Reed standard cell will come to the next class and other things. Another thing you have to know the leukocytic common antigen, that is the CD45. All the lymphoid neoplasm, you don't know that cell look like the lymphocyte, but you don't know it is a lymphoid or is a polydifferentiated carcinoma or sarcoma, you don't know. So LCA is a marker for B cell marker, that is the CD45. This big thing for CD markers for all the organs, I am not going. Now, overall frequencies are non-Hodgkin lymphoma, how much it is? It is a 62%. Hodgkin lymphoma 8%, plasma cell disorder already we learned this is 16%, and CLL is the 9% and 4%. These are the lymphoid neoplasm are the percentage. But non-Hodgkin lymphoma is top, that is the 62%. And we are not going to this relative lymphoid neoplasm of NHL group. Most commonly you occur the DLBCL or diffuse B-cell lymphoma, 31%, follicular lymphoma, that's 22%. These two is the more common. Another thing is the Burkitt lymphoma, 2.5%. So we'll learn only the follicular lymphoma, diffuse large B-cell lymphoma, and few minutes about the Burkitt lymphoma. The big category, big, all the no needed. Only the few name of that NHL group we will learn. One important translocation, you have to know the follicular lymphoma give rise to a suppression of apoptosis. This is the BCL2, 1480 translocation. Sometimes in the MCQ they'll ask. So this is the follicular lymphoma responsible for 14-18 translocation of BCL2 gives rise to a suppression of the anti-apoptotic oncogene, give rise to a follicular lymphoma. Diffuse large B-cell lymphoma, that is a BCL6 origin, that is a translocation of 3-4 translocation. Then Burkitt lymphoma, 8-14 translocation, that CMYC. So these are the three things for remember for oral purpose and MCQ purpose. Peripheral B-cell lymphoma, CLL already you learned, will go to the follicular lymphoma. Few points in favor of follicular lymphoma. What are those things? It is a 22% of NHL. Associated with the B-cell translocation, this is the hallmark, that is a 14-18 translocation, BCL2 translocation on chromosomal 8. Morphology, it occurs in the lymph node, usually in the nodular fashion. It may be a nodular or diffuse, both pattern you can get. And if it is biopsy, you can do the mixture of the cells may be of centrocyte and centroblast and centrocyte, mixture of these two elements. In the follicular architecture of lymph node, if we do the CD markers, you can get both type of centrocyte and centroblast cells are affected. Predominantly centrocyte. Peripheral blood, you can get that spillage of those cells, that is centrocyte, and bone marrow also involved by this lymphoid tissue. See this thing? This is the follicular architecture of that lymph node, and this is the reactive follicle. BCL2 usually reactive when it is the germinal, peri-germinal center, they produce the BCL positive. But when it is a follicular lymphoma, the germinal center are BCL2 positive. So this thing we can identify the what type of cell it is origin, and the clonal polyculation of what type of molecular analysis give rise to the diagnosis. Then diffuse large B-cell lymphoma, it is usually arising from the BCL6, mostly common, maybe in the nodal site or maybe in the extranodal site, and it is very aggressive and rapidly progressive lymphoma. Morphologically, it is diffuse pattern and mixture of very atypical cells, is a large nucleus, vesicular nucleus, irregular lobated nucleus, and moderate amount of those multiple single or multiple nucleoli. And anaplastic multinucleated giant cells also we can get, and prognosis is very poor. Morphologically, this is the lymph node, large, grossly it is matted and fish plus appearance, and this marker is positive for BCL6 deseparation, BCL2 translocation, and CMYC chromosomal 8 translocation. So these are the some feature for DSBCL. No need to remember only the chromosome and that oncogene, they are responsible for follicular lymphoma, DSBCL. Only for exam purpose, this much is enough for you. This is the lymphoid tissue. This is the large node. This is a follicular architecture, but it's a diffuse type of analysis. See, this is the positive for BCL6 positivity. Cells are large, multiple or single prominent nucleoli, may have this multiple nucleoli. So this is diffuse pattern of this thing. Now another thing is the Burkitt lymphoma. You have to know for exam purpose, for MCQ sometimes they ask, this here the highly proliferative B-cell neoplasm, it is only 2.5%. Category what different types, African type, sporadic type, and aggressive type. African type of lymphoma, Burkitt lymphoma usually is an endemic area, but sporadic type usually is a non-endemic area. Endemic area is a African type, but Asian type it is a non-endemic. And another is the more aggressive is if the patient is arising from the HIV infection, they are produced this type of lymphoma. Histology, all these categories are similar, and translocation হচ্ছে CMYC gene, that is 8-14 translocation, and immunoglobulin kappa and lambda translocation. These are the common features of Burkitt lymphoma. What is this thing? These patients are usually affected by EBV virus infection. When the EBV virus infection occurs, they give rise to a latent LMP protein once they are present in their system, and that LMP protein are responsible for this lymphoma. So patients are usually affected by the EBV virus, and their protein from this virus is LMP protein, latent membrane protein antigen 1. Morphologically, usually they are affected mandible, maxilla, orbit, and CNS. And these cells are diffuse proliferation of intermediate cells. You know that already. You know that ALL they have L1, L2, L3 type. So L3 type is Burkitt type of cell. That is also you know LL পড়ানো হয়ে গেছে, ALL পড়ানো হয়েছে তোমাদের হয়নি, অ্যাকুট লিম্ফোপ্লাস্টিক লিউকেমিয়া পড়ানো হয়নি, হয়েছে? তাহলে L3 type of cells are Burkitt like cell. That's why you have to know what is the Burkitt lymphoma. The cell are similar. See this thing. These patients are endemic type, that is the maxilla, mandible, eye and CNS can affected, usually children. But endemic type, the sporadic type, that lymph node, the abdominal lymph node, they are affected. So these are the things the patient are presented with this. Endemic area, that is African type, non-endemic, that is the sporadic type, usually Asian people, they are affected. And this, due to this proliferation of these cells and excessive apoptosis give rise to this thing is a starry sky appearance. Very important in Burkitt lymphoma, the morphology of the lymph node are transformed to a Burkitt is a starry sky appearance. What is this thing look like? This is this sky and this is a star-like things due to this apoptosis. That is the specific for Burkitt lymphoma, starry sky appearance. When the lymph node are effaced and this morphology give rise to starry sky appearance. See this thing. You have a contact with this thing, the L3 blast, ALL L3 blast, the cells are Burkitt like. What are these things? The cells are large size, coarse chromatin, deep blue cytoplasm, and this vacuole, the lipid vacuole, that is the Burkitt cell in the Burkitt lymphoma. When it is present in that ALL or acute lymphoblastic leukemia, the cell is characteristically is called the Burkitt-like cells. The exam they will ask L1 blast, L2 blast, L3 blast in ALL. So this cell, why it is important? Because you are related to this ALL and that morphology of cell is important to identify. That is the Burkitt-like cell in the ALL and here is the Burkitt cell. Clear? So large cell, coarse chromatin and deep blue cytoplasm and cytoplasmic vacuolation. So B cell lymphoma NHL is clear. Now we'll go to the salient point. You have to know the T cell lymphoma. That is, it is occur usually in the skin. Produce the T cell mycosis fungoides and start. That's a Sézary syndrome. You have to know only these two entities originated from the T cell lymphoma. And that is the Sézary syndrome and mycosis fungoides. This is from the skin infection. Patient presented with this thing. And here is that when this thing from the skin gets spillage in the blood, they produce this, the cell is look like eczema-like feature. When go to the blood, the Sézary thing or the cerebriform nucleus look like cerebriform was the brain-like architecture in the peripheral blood. Only you know the T cell lymphoma leukemia is affect the skin when their B cell are affected in the lymph node as well as the extranodal. But T cell lymphoma, they produce in the skin as eczema-like features and it's called the Sézary syndrome or mycosis fungoides. And the eczema-like lesion when enter within the blood system in the peripheral blood, the particular cell, the Sézary-like cell, that a cell is called Sézary cell and look like this cerebriform architecture. So this is the whole thing about this NHL. This patient, see this thing, mycosis fungoides, skin eczema-like lesion. Now that staging is important for the clinician for planning of treatment and the prognosis of the treatment. What is this? An Arbor classification of the staging, stage 1 to 4. Stage 1, only one group of lymph node above the diaphragm. Stage 2, more than one group of lymph node above the diaphragm. 3, both above the diaphragm, different groups of lymph node, but when all the other organ, remote tissue are involved, that is stage 4. And with presence of these symptoms that I told, and this clinician, they plan their operation or treatment strategy according to the stage of the patient for their prognosis and outcome. So this is the nutshell of NHL that you have to know. For example, the cell of origin, what are the different types of cell origin and what is the outcome. That is the non-Hodgkin lymphoma. It is a big thing. No need to remember all those things. Only you know that B cell origin, T cell origin and NK cell origin, and outcome and prognosis due to the molecular analysis. Next class we will go to the Hodgkin lymphoma for exam purpose tomorrow. Next. So what is the prognosis of NHL? Depending upon the stage of the disease or molecular expression, 5-year survival rate is 74%. But with therapy, that due to chemotherapy, radiotherapy, targeted therapy and immunotherapy, they are give us to the good prognosis, and patient can predict with this responsible for how they present or survive with this treatment. Sometimes the stem cell transplantation also tried for that treatment. So today's class only you know what is the lymphoid neoplasm, what is the two groups, that is the NHL and HL. Non-Hodgkin lymphoma, what are that area, and Hodgkin lymphoma will go for tomorrow for exam purpose and oral purpose. Sometimes they ask for what is different types of Hodgkin lymphoma, what are the particular cell present, write down. Last exam already students they got that type of different types of Hodgkin cells that present, draw the diagram. So tomorrow we'll do that times. Now it is okay? Now any question or any hard? So only you remember this thing only, that what is two group non-Hodgkin lymphoma and Hodgkin lymphoma, and how they classify. No need to the big classification, only that area you know.